Welcome to the deep dive. If you look at a television commercial for baby products, you are going to see like the exact same imagery every single
Oh,
time.
yeah, every time. Soft lighting, peaceful lullabies.
Right. A perfectly serene nursery and a completely radiant, just totally rested parent. But today, we are tearing that picture up.
It really needs to be torn up. I mean, that curated imagery is actively doing damage.
Yeah, we have a specific mission today for you, the learner. We are analyzing a really comprehensive clinical guide on perinatal wellness and postpartum depression, or PPD.
Right.
And we're also looking closely at how a telehealth practice down in Georgia, coping and healing counseling, is basically completely rewriting the rule book on how this condition gets treated.
It's a really necessary rewrite, too.
For sure. So whether you are a prospective parent, a partner trying to support your spouse, someone who's currently just in the trenches of the newborn phase, or just, a curious mind wanting to understand the human brain under extreme stress, this one is for you. Okay, let's unpack this. Because the gap between the the cultural expectation of bringing a baby home and the clinical reality we are looking at in these sources is, well, it's staggering.
It is a massive gulf. I mean, we are
Yeah.
talking about a physiological and psychological upheaval
Mhm.
that society largely just tries to brush off.
Yeah, like it's nothing.
Right. The goal today is to separate hard medical fact from cultural fiction.
Mm.
There is this intense societal insistence on, like, glowing perfection.
Oh, the glowing new mom trope.
Exactly. And that ends up confusing standard exhaustion with an actual medical crisis, leaving real, highly treatable conditions to basically fester in the dark.
Well, let's start with establishing a baseline, because I think a lot of people assume that if you have a baby, you are just going to be miserable, exhausted, and, weeping for a while.
Just powering through it.
Right. And that is just the price of admission.
Well, to understand how severe clinical PPD actually is, we first have to look at how medicine defines the standard baby blues.
Which is super common, right?
Incredibly common. And they are a direct result of biology. After childbirth, a person experiences the steepest drop in hormones a human being will ever go through.
Wow, ever.
Ever. Estrogen and progesterone just plummet off a cliff.
Mm.
So right around days 3 to 5, you see intense mood swings, crying spells, irritability.
Okay, so that's the physical crash.
Yeah, but the defining characteristic of the baby blues is that this state is entirely transient. The neurochemistry stabilizes, and the symptoms resolve completely within 2 weeks.
2 weeks. Okay, so it's a temporary, albeit really intense biological crash. But if we move past that 2-week mark and the symptoms are not fading, like if they are intensifying, we are no longer in the territory of the baby blues. We're looking at postpartum depression.
That is the line of demarcation, duration and intensity.
Wait, let me challenge that for a second. Because how does a new parent in the thick of it actually distinguish that?
It's really hard.
Right, because if my baby is waking me up every 90 minutes around the clock, I mean, I am going to be irritable, my brain is going to be foggy, and I am going to feel empty. How is that clinical depression and not just the circumstantial reality of having a newborn?
That's the million-dollar question.
It feels like asking a smartphone why its battery is low when you've been playing a video game on full brightness for 10 hours. The phone isn't broken, it's just being drained.
Okay, what's fascinating here is that is a brilliant way to frame it. But here is where the mechanism of clinical PPD diverges from circumstantial exhaustion.
Okay, lay it on me.
In your smartphone analogy, circumstantial exhaustion means the battery is drained, but if you plug it into the wall, it immediately starts to recharge.
Right, you get some juice back.
Exactly. But with PPD, the battery itself has become fundamentally corrupted. It cannot hold a charge, even when it's plugged in.
Oh, wow. Okay, so what does that look like in practice?
Practically, it looks like a parent who has a sleeping baby and has a partner who says, hey, I will take the night shift, you go to sleep.
The dream scenario.
Right. So that parent goes to bed, is bone tired,
Mm.
but absolutely cannot sleep. Their nervous system is just locked in this state of hyperarousal.
Like they're wired.
Yes, they are pumping out cortisol and adrenaline because the brain's regulatory system is essentially broken. It's not just a lack of sleep. It's a clinical sleep disturbance.
So the environment is offering rest, but the biology actively rejects it.
That is clinical PPD. It is a fundamental nervous system dysregulation. And the Diagnostic Manual for Mental Health, the DSM-5, has a very specific caveat for this.
Which is?
While PPD typically onsets within the first 4 weeks, The diagnostic specifier allows for symptoms to emerge up to 12 months after birth.
Wait, 12 months?
Up to a full year, yes.
That means a parent could be, like, celebrating their child's first birthday, thinking they're finally out of the woods, and suddenly get hit with a severe clinical depressive episode.
Exactly. It's not just a first-month problem.
And we should probably clarify what these symptoms actually entail, because looking at the sources, it goes way beyond just feeling sad.
Oh, absolutely.
Ah.
It's much deeper than sadness.
We are talking about persistent emptiness, a complete inability to feel pleasure, extreme shifts in appetite. And this one really stood out to me, a profound difficulty bonding with the baby, coupled with an intense feeling of worthlessness regarding their ability to be a parent.
Yes. And in the extreme end of that spectrum, we also see postpartum psychosis.
Which sounds terrifying.
It is. It's much rarer, affecting roughly 1 to 2 per 1,000 births. But it is an absolute medical emergency. It involves hallucinations, paranoia, and a complete break from reality, requiring immediate hospital evaluation.
Right, right. Let's shift to the psychological weight of this, though, because there is one mental phenomenon in this data that genuinely shocked me.
I think I know what you're going to say.
It's a symptom referred to as intrusive thoughts. And the way this is described is nothing short of terrifying.
It is easily one of the most isolating, silent burdens a new parent can experience.
They are defined as unwanted, highly graphic, deeply distressing thoughts about the baby being harmed. But if I am a new parent and I'm sitting on the couch and suddenly I just visualize my child getting hurt or worse, I visualize myself doing it, my immediate assumption is going to be that I am losing my mind.
Of course it is.
Or that I am like a subconscious threat to my own kid. I honestly do not understand how a clinician can hear a parent say, I am having thoughts of harming my baby, and definitively separate that from actual physical danger.
That fear you just articulated is the exact reason parents suffer in silence. Their terrified child protective services will be called and their baby will be taken away.
Yeah, who wouldn't be?
But the clinical mechanism here is crucial to understand. Psychology classifies these specific thoughts as ego-dystonic.
Okay, break that down for me. Ego-dystonic.
So ego refers to your core sense of self, your values, your desires.
Okay.
And dystonic means in opposition to. So an ego-dystonic thought is completely alien and repugnant to what the person actually wants.
It's against their nature.
Exactly. It is essentially an anxiety disorder misfiring. The brain is hypervigilant, desperately trying to protect this fragile newborn, so it just starts catastrophizing. It generates the worst-case scenarios imaginable as a really warped sort of threat assessment mechanism.
So it's like a glitching fire alarm. It is blaring at 140 decibels, making you panic about a fire. But the alarm itself isn't the fire. The brain is just malfunctioning in its attempt to keep the baby safe.
That is a perfect analogy. And the way a clinician distinguishes an ego-dystonic intrusive thought from a genuine threat is by observing the parent's reaction to the thought.
Their reaction.
Yes. A parent with postpartum psychosis who poses a real danger might experience ego-syntonic thoughts, meaning the thoughts align with the delusional reality that they actually accept.
Okay, I see.
But a parent experiencing ego-dystonic intrusive thoughts is horrified by them. The sheer distress, the anxiety, the intense guilt they feel about the thought is the clinical proof that they do not want to act on it.
Wow. So the panic is actually the proof of safety?
Yes. The anxiety proves their moral compass is fully intact.
That's incredible.
It is. But cultural norms completely hijack this reality. Society pushes this myth of the good mother, this idea that maternal instinct is pure, serene, and naturally blissful 100% of the time.
Right, back to the TV commercial.
Exactly. So when a mother has a dark, ego-dystonic thought, she measures it against that impossible cultural standard and concludes she is a monster.
And so she doesn't tell anyone. Which means she never gets to sit in front of a professional who can just look at her and say, hey, this is ego-dystonic. You aren't a danger.
Exactly.
I mean, the relief of just hearing the mechanics of what is happening in your brain must be profound.
The relief is immediate and life-changing. But getting them into that chair is the problem because the silence is deafening. We are looking at a condition that affects roughly 1 in 7 birthing parents in the United States.
1 in 7?
It's a massive public health issue that thrives in the dark.
Well, here's where it gets really interesting for me. Because you say 1 in 7 birthing parents, but the data throws a massive curveball.
Oh, the partner data.
Yes. It states that about 10% of new fathers, or non-birthing partners, also develop postpartum depression.
This is a critical point. that almost never makes it into mainstream parenting discussions.
I honestly have to stop you and ask for the mechanics of this because we just established that the baby blues and the onset of PPD are heavily tied to that biological crash of estrogen and progesterone after childbirth.
Right.
If a partner did not physically give birth, they don't have that hormone crash. So how on earth are they developing clinical postpartum depression?
Because it challenges the old school assumption that PPD is purely a female hormonal issue.
Yeah.
Modern medicine views PPD through a biopsychosocial lens.
Biopsychosocial, so biology, psychology, and social environment.
Exactly. All intertwined. For non-birthing partners, you strip away the sudden estrogen drop, but you keep the extreme chronic sleep deprivation.
Ah, the sleep.
Right. Prolonged sleep deprivation doesn't just make you tired, it fundamentally alters brain chemistry. It depletes serotonin and dopamine, and chronically elevates cortisol, the stress hormone.
So the environmental stress literally rewires the neurochemistry to mimic the hormonal crash.
It does.
Yeah.
And when you add in psychological shifts, the overwhelming pressure of providing for a new life, the massive disruption in the relationship dynamic, the brain enters the exact same depressive state. It is a profound environmental and psychological trigger.
That blows the whole "it's just a women's hormone issue" stereotype completely out of the water.
We're really out in the water.
It makes sense then when you look at the other risk factors listed. Things like a prior history of depression or anxiety, a traumatic birth experience, a baby being admitted to the NICU, or severe financial stress.
Or even a history of PMS or PMDD and thyroid dysfunction.
Right. These are environmental and physical triggers that act like a sledgehammer on the nervous system, regardless of who actually gave birth.
And it explains the stark disparities we see in the healthcare system. Communities of color and low-income families face significantly higher risks for PPD simply because they are carrying heavier loads of environmental and systemic stress.
And often with far less caregiver support.
Exactly. Yet these are the very populations that go vastly underdiagnosed.
Which brings up a glaring question. If parents are hiding their symptoms because of guilt, and marginalized communities are slipping under the radar, who is supposed to be catching this?
That is the problem.
I mean, you look at a newborn schedule, and they are at the pediatrician constantly in those first few months. But those visits are hyper-focused on the baby. They are checking the baby's weight, the baby's reflexes. The parent might as well just be the stroller pushing the infant into the room.
That's a great point. The medical focus is entirely on the infant, and the care for the birthing parent is even more disjointed.
So,
Typically, obstetrical care ends with a single, abrupt checkup at the 6-week mark.
just one checkup.
1. The clinician verifies that the physical trauma of birth is healing, clears the patient for normal activity, and that is it. The medical safety net simply vanishes.
But wait, we just said the DSM-5 allows for PPD to emerge up to 12 months postpartum?
Exactly.
So the medical system drops the parents right when the compounding exhaustion might be peaking and well before some of the most severe depressive episodes even begin.
Yes.
We have a system where the good mother myth silences the patient and an arbitrary 6-week cutoff blinds the doctor.
It creates a perfect storm where the people suffering the most are the least likely to be seen.
Okay, so if the medical system is dropping the ball at 6 weeks, where is an exhausted, financially strapped parent actually supposed to go? If they push past the guilt and decide they need help, what are the tools that actually pull a brain out of this state?
Well, the outlook is actually very hopeful if they can access the tools. We have highly validated treatments.
Like what?
Therapy is the frontline defense. Specifically, cognitive behavioral therapy, or CBT, alongside interpersonal therapy, or IPT.
Let's break those down because therapy is such a vague word. How does CBT actually fix a brain struggling with PPD?
So CBT is all about identifying and restructuring cognitive distortions.
Okay.
For example, if a mother's brain is looping on the thought, "I couldn't breastfeed today, therefore I am a complete failure and my baby will suffer," CBT teaches her to intercept that thought. She learns to examine the evidence rationally and reframe it.
Got it. So it essentially acts as a brake pedal to stop the downward spiral of catastrophizing.
Exactly. It stops the loop.
And interpersonal therapy. Because IPT is highlighted in the sources as being specifically validated and highly effective for perinatal depression.
Yeah, IPT approaches the problem differently. It focuses heavily on the massive life transition and role changes.
The identity shift.
Exactly. Think about the psychological earthquake of becoming a parent. You go from an independent adult to a 247 caregiver. Your relationship with your partner is completely upended.
Understatement of the year.
Right, so IPT directly addresses those relationship shifts. It helps the parents negotiate their new identities and resolve the massive interpersonal conflicts that inevitably arise when you drop a screaming newborn into a marriage.
Beyond therapy, there are medical interventions as well, right? The sources mention medication options like sertraline that are considered safe during breastfeeding when coordinated with an OB or a psychiatric provider.
Yes, medication is a very valid path.
And there are even adjunct therapies like bright light therapy and structured exercise that help reset the circadian rhythm.
Which is huge when you aren't sleeping.
Right. And of course, we have to mention the absolute baseline emergency protocol. If there are any thoughts of self-harm or an actual desire to act on harming the baby, that requires an immediate call to 988 or a trip to the emergency room.
Absolutely. Non-negotiable.
But let's look at the logistics here, because telling a new parent to just go to therapy is like telling someone drowning to just swim to shore.
It is a profound paradox.
Yeah.
The people who need the most therapeutic support are in the absolute worst logistical position to go get it.
Imagine the sheer physical labor of it. You have to pack a diaper bag, time the feeding perfectly so the baby isn't screaming in the car, drive across town, find parking, and then sit in a sterile clinical waiting room for 50 minutes.
It's a mountain to climb.
It really is. And that is why the model presented by Coping and Healing Counseling CHC down in Georgia is so compelling to me. They aren't just offering therapy. They are fundamentally changing the delivery mechanism.
They are removing the mountain entirely.
Yes.
CHC operates a 100% IPK-compliant telehealth model. They have a team of over 15 licensed therapists, clinical social workers, professional counselors, marriage and family therapists, and they serve all 159 counties in the state of Georgia.
It's like building the bridge right into the person's living room. Telehealth turns the couch during nap time into a clinic.
That's exactly what it does.
You don't have to hire a babysitter. You don't have to leave the house. You can literally talk to a professional while rocking the baby or, folding laundry.
And they tackle the financial barrier just as aggressively. We discuss how financial stress is a major trigger for PPD.
Yeah, huge trigger.
Well, CHC accepts commercial insurances. Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, Humana, and those copays typically sit between $10 and $40 a session.
Which is very accessible.
It is. But the game changer here is that for patients on Medicaid, the copay is $0.
$0.
Zero. No travel, zero cost for Medicaid patients.
That is unbelievable. Same-week scheduling, culturally competent care, all from your own home. If you are listening from Georgia, you can go to chtherapy.com or call 404-832-0102 and actually get help before the end of the week.
Which is vital, because it does not matter how incredible interpersonal therapy is if a low-income mother in a rural county cannot physically or financially get into the room with a therapist.
Right. The access is everything.
Exactly. The CHC model recognizes that accessibility is the medicine.
Yeah.
You have to adapt the system to the exhausted patient, not force the patient to adapt to the rigid structure of the system.
So what does this all mean for you? Today, we took a hard look at the reality of postpartum depression. We separated the transient baby blues from the very real clinical distress that can emerge up to a year later. We broke down the terrifying mechanism of intrusive thoughts and hopefully showed you that the horror you feel at a dark thought is the very proof that you are safe.
A really important takeaway.
Definitely. We looked at how partners are biologically and socially pulled into the exact same neurochemical crashes and how telehealth models like CHC are finally meeting parents where they are.
The overarching takeaway here is that we have to actively dismantle this curated image of the good mother or the perfect parent.
Wow.
It is a toxic standard that forces real, terrifying suffering into the shadows.
So true. If you are listening to this and you are staring blankly at the wall right now while your baby sleeps, or if you are terrified of your own thoughts, I want you to hear this clearly. You are not failing.
No, you are not.
You are experiencing a documented, highly treatable neurobiological response to a massive life event. The guilt you feel is a liar.
Well said. And to leave you with something to consider as we close, we spent a lot of time on the systemic blind spots today, particularly how obstetrical care evaporates at 6 weeks.
Yeah, the arbitrary cutoff.
Yeah, if that arbitrary cutoff is missing the bulk of severe postpartum depression, what would happen if we completely restructured postnatal care?
What would that look like?
Imagine a system that focuses equally on the physical and mental health of the parent for the entire first year of life. How might that fundamental shift change the long-term health trajectory of our families and our society for generations to come?
Wow. It makes you realize how much suffering is entirely optional if we just build the right safety nets. Thanks for joining us on this deep dive.